a real pleasure to be here. This at the outset, I might just add here or say, when Jay called me saying that, sir, this is a topic that we are giving you, and I went through other topics of the conference. I said, let me talk something completely offbeat, and I have been doing this for the last 4.5 years very intensely since 2019. I thought I will share that with you. So my talk today is artificial intelligence in cardiovascular medicine, the good, the bad, and the ugly. My first question to all of you all is, how many of you, by the way, how many of you are students here? Fantastic. Fantastic. Why the students don't are sitting back at the back? Please come forward. Please, there are so many chairs vacant here. Come forward. Because it's going to be a roller coaster ride. So the way you board the flight, they say, sit back, enjoy and relax. Relax and enjoy the ride. I would not tell you to sit back. Sit at the edge of the seat, because that is going to make you enjoy this talk. All right. So what is artificial intelligence? Artificial intelligence is a process of unifying mind and machine through human brain and computer interfaces. The term was first coined by John McCarthy in a conference on science and engineering of making intelligent machines way back in 1956. So in healthcare, it all is about unifying human mind and machines. In other words, the theory and development of computer systems which are able to perform tasks that normally require human intelligence, such as visual perception, analyzing histopathology images or X-rays or angiograms, speech recognition, decision making, and translation between languages for the layman, but also to do tasks beyond human intelligence. And there, Elon Musk just said 6 weeks ago, scientists have got only 10% chance of making artificial intelligence safe. So we are there heading towards a target which could be quite dark and ugly at the end of the day. And this is a photograph of a 18th century physician, who used to sit by the bedside of an ailing patient. They will observe the patient for hours. The breathing pattern, the pallor on the face, the pulse, they would even smell the breath to get to the diagnosis. And you see here, you are not seeing this man. All right? This man was an assistant staying in the shadows and watching the patient from another angle, just in case the physician misses some observations. Just like Sherlock Holmes had Watson, right? Same way. Now, we are replacing that assistant with artificial intelligence. And that is how it could be. So, the fathers of AI are Marvin Minsky and John McCarthy. If you ever read the first article of Marvin Minsky in a 1976 journal, you would be amazed to see this guy's foresight into future. I think those are the guys which we call visionary. We are just hard workers. We just cannot even use the existing knowledge properly. These were visionaries. So, artificial intelligence is any technique that allows computer systems to mimic human brain. What is machine learning? A subset of AI that uses statistical techniques to enable machines to learn from data. When in 1918, I started taking interest in this field, and suddenly I came to know one of my pediatrics friend who is working in Muscat now, my classmate. His daughter, after doing MBBS from Andhra, told his dad, because of you I did MBBS, I've never wanted to do that, but now I'm going to do what I want to do. And she entered this field. Her name is Sindhu. I contacted her, and when she came first on the Zoom, for the first 10 minutes, I thought an alien is talking to me. I couldn't fathom anything. Everything went tangent, And she said, uncle, because she was so small when we were in MBBS. So she said, uncle, I think you are getting lost. Please don't. You are a doctor, and what I'm talking to you is from parallel universe. These were the two words which took me off my seat. She said, there's a parallel universe out there, uncle, and that is happening And no matter whether you like, whether you don't like, whether you hate, whether you like, whatever, you will have to be with it. And she said, just another decade and doctors will be classified into two. Doctors who are with AI and who don't know AI at all. That's about it. So, supervised learning is where AI is today. Machines learn explicitly. We give machine a labeled data with clearly defined inputs. I will show you some examples of that. And then resolve classifications and regression problems. So unsupervised learning is where some of the algorithms have already reached. One EP algorithm which Yash will clarify in his talk about sudden death prediction from a surface ECG done 20 years ago. That is called unsupervised learning. And reinforcement learning, where machine learns how to act in certain environment without you ever having trained that machine to react. The machine will act. All right. So that is something. See, for example, supervised learning has 5 facets, and it took me almost 3 months to understand what does this mean. But I request you not to go in details of that, but just to clarify, artificial neural network, support vector machines, which we are using in ecos now, fuzzy logic, which is used in electrophysiology and cath labs, and K nearest neighbor, KNN, which is used for epidemiological population-based models to produce or to predict all-cause mortality and disease patterns. Now, what is good? Do we really need AI in cardiology? Yes. Cardiology practice is becoming more and more complex. It is becoming hard to properly make sense of all data and face the workload of human modern medicine. Humans take images as a series of photons in their retina and pursue them through visual system. Haven't you seen a single angiogram recorded as 50% lesion by one cardiologist, 70 by the second, and 90 by the third? Haven't you? Right. That is human perception, and some information is invariably lost in this process. AI models can directly pursue raw data as they are with phenomenal speed and accuracy, which has the potential to minimize bias, data loss, and noise. It has phenomenal accuracy. I'll show you some clips of that. By combining different inputs of data and different processing methods, then AI can see an ECG like no one has seen before. No human has seen before. Mildest of the deflections in the P wave amplitude, P wave breadth, the negative component of P wave in V1, its width and its depth, the way AI can analyze, humans can't. Just can't. We don't have that ability. And then the AI can integrate that when a lot of data is fed over a period of years along with the echo data to predict whether this man is likely to develop ejection fraction poor over 10 years follow. I will show you some. So the good part is natural history of the disease. Metabolic and physiological abnormalities take over years. You are asymptomatic, you feel great, and then symptoms and signs develop. But by that time, it could be too late because the first symptom could be stroke, heart attack, or even death. Is ejection fraction low? So a single heart cell is important for myocardial contraction. It is also important that it gives an electrical voltage on the surface ECG. And then the ECG recorded from body surface. This is widely available, inexpensive, painless test. But when you feed hundreds and thousands of echocardiograms of thousands of patients, followed up for 10, 15, 20 years, and their simultaneous good quality echocardiograms over a period of time, you form an algorithm. One such algorithm was formed by Sindhu and is now patented by Mayo Clinic. And I will show you what does it show. The area under curve is 0.9 almost. Area under curve is 0.93. What does that mean? That means a surface ECG can tell you whether this patient is likely to have a low EF or not. You will tell me, what the hell, Dr. Ponde? I have a echo machine available in the casualty. Well, in India, we are lucky. In US or UK, to get an echocardiogram appointment, it takes average 3 weeks, right? So which patient should go prioritize to be echo will be done by this ECG. And there was a prospective validation of deep learning electrocardiogram algorithm for the detection of left ventricular systolic dysfunction. Proudly again, this algorithm was completely and thoroughly conceived by Sindhu. Artificial intelligence enabled ECG algorithm to identify patients with left ventricular systolic dysfunction in the emergency room. In ER, patient comes breathless. First, what is done? ECG. Whether this ECG suggests left ventricular dysfunction or not. A phenomenal study, 18,000 patients, and what is important, AI ECG outperformed NT-proBNP. Because NT-proBNP, the downtime is 3.5 hours. You send a sample, you get a result, minimum 3.5 hours in the best of the lab. Even my lab takes 3 hours. Examples. 35-year-old asymptomatic man presents after his sister dies suddenly. And therefore he thought he'll get his ECG done. What do you think about the ECG? Looks quite okay, right? It looks normal. But the AI ECG said this patient has 76% probability of having low EF. Patient went for echocardiogram, ejection fraction was 18%. Diagnosis, familial dilated cardiomyopathy, phospholamban C. Right? Next patient, 28-year-old male. Look at the ECG. V2, V3 shows biphasic T waves. Something like maybe ACS, but this patient had not come for chest pain. This patient was come for a perfectly normal health checkup. AI ECG was positive for low EF. Patient was sent for an echo, but the echo showed normal, near normal EF, 50%. So the AI ECG was false positive for low EF, right? But 5 years later, the same guy develops ejection fraction of 31%. Then Friedman, Jashi Etia, and Patricia Pellica, these are the 3 big guys in AI. They collected all this humongous data. And look at this. These light green bars are patients in whom the AI ECG shows low EF. Index time, the patient doesn't have low EF. But over 12 years, almost 1/3 develop low EF. As against, when the AI ECG shows normal EF, only 10% develop poor EF over 12 years of follow-up. What does this mean? This means that a single myocardial cell voltage that is expressed on the surface ECG, if analyzed in a specific manner with humongous amount of data, can predict a patient developing left ventricular dysfunction over 10-year follow-up with an accuracy of 0.93, almost 100%. All right. Going ahead, when this was adopted clinically in a primary care model, people or patients or physicians who adopted AI ECG were 3 times more likely to detect left ventricular dysfunction as compared to those who did not adopt. Now, can that be scalable to an Apple Watch or a Galaxy Watch? Not a 12-lead ECG, just an Apple Watch ECG. So a great study was done by again Attia, Harman and Dugan on prospective evaluation of smartwatch enabled detection of left ventricular systolic dysfunction. 18,000 patients and odd. An AI algorithm detected patients with low EF with an area under curve of 0.9. Right? So, but you need a longer recording. You need a recording of 3 minutes. So every volunteer gave a 3-minute recording of smartwatch ECG, not 12-lead also, not 12-lead. Yet it could detect left ventricular systolic dysfunction. And then a randomized trial. The Eagle trial, which you all know, was close to 22,000 patients over 8 months, 120 care teams, and AI was effective in diagnosing EF lesser than 35%. Now, where are we going? In Hinduja, 4 months ago, we started a trial with a ELEPT program. It is echo for left ventricular systolic dysfunction, but it's not only, echo is the company, not echo. There is a stethoscope which you put on the patient's chest. It records the phonocardiogram, that means heart sounds. Simultaneously, you put this on the chest, it records 2-lead ECG, that's it. 1 and 2 and 1 and AVF. So right arm and left leg, and right arm and left arm. Just two leads, two limb leads, and a phonocardiogram, and that can detect left ventricular systolic dysfunction. So we are planning to study 1,600 patients. We have finished around 370 so far. Let's see. Can clinical practice be modified because of this? Yes. Countries where echos are not available at a drop of a hat, it can be. Can ECG predict biological age? Now, Dr. Hiremat just said, social isolation makes you physiologically older. Married people live longer, whether the marriage works or not, irrespective. Whether you fight or kill each other, yet you live longer. So, acute illness makes you physiologically older. Obesity makes you physiologically older. Biomarkers of biological age, we all know. And the biggest biomarker which has come in the last 10 years is cystatin C. Cystatin C has outperformed all the other biomarkers for older age. And of course, lamine AC deficiency. We know that lamine AC is a protein which maintains structural integrity of the cell nucleus. It regulates gene transcription, cell differentiation, epigenetic regulation, and DNA repair. And the LMCA gene encodes lamine AC. Now, are we going to do all this genetic 25 biomarkers test in every individual? No. You just do a surface ECG. Just a surface ECG. Feed it to the AI. Example, it gives you real age versus biological age difference. Area under curve, look at here, 0.97. Example, 35-year-old woman presents with a cardiovascular prevention clinic. She's 106 kgs in weight. The AI ECG says her age is 41 years. She's 35 years. So the AI ECG says she's biologically older. Metabolic syndrome patient, right? That Dr. Jagrevan just said. And the same patient undergoes another ECG a year and a half later. Now this ECG says she has now her age is 36 years because in those 36 months she has lost 10 kgs of weight. So ECG can tell you your biological age versus your chronological age. So this one patient, again published by Friedman's group. This is the ECG age. This is the real age. He was 38. The AI ECG said he is 55. Why? Ejection fraction was 25%. Kept on going. At the age of 51, the AI ECG said his age was 62. Suddenly, at his age of 53, he had some therapy. And at his age of 55, AI ECG said he is 50. What happened? What happened? He got a transplant from a 20-year-old donor. So, that is what AI can do. Madurai Eye Institute, as you know, their pivotal work, Dr. Jayagopal must be aware, about oculomics predicting cardiovascular disease. And what they did was, in this happened in COVID pandemic actually, a paper published in 2021, they fed thousands of retinograms and the patient's history to an AI algorithm. And now a single retinogram image can tell you whether the patient has diabetes, likely to have hyperlipidemia, what is the duration of the hyperlipidemia, and even the average life expectancy. So going ahead, change can be scary. But you know what is scarier? Allowing fear to stop you from growing, evolving and progressing. Symptomatic AF, Yash is here, and you have subclinical AF, which is common, undetected and associated with stroke. And now artificial intelligence ECG can even predict patients who are likely to have AF in future. So this is a patient in whom an index ECG is taken, patients with no previous atrial fibrillation ever, and you follow them up over months. Here is the ECG of a patient who has had paroxysmal AF, and the ECG can predict that by the end of March, he probably have another episode of AF. It can tell you that. Area under curve, 0.90. So AI ECG calculated AF probability almost equals to the charge AF score derived probability. So it is mind-boggling what is happening there in the parallel universe, and to the extent that even detection of left atrial myopathy using AI ECG is very, very strong. So if you see your left atrial reservoir strain, left atrial volume index can be, what is the likelihood that this patient has left atrial myopathy can be told to you by a simple surface ECG algorithm. That algorithm is called 2091C algorithm of AI ECG. Similarly, as you use these ECGs, suppose AI says probability of left atrial myopathy is 1%, the echo is almost always normal. Whereas when AI says probability of 85%, you will see dilated LA, secondary mitral regurgitation, E by E prime elevated, and pulmonary artery systolic pressure elevated. Okay, electrocardiogram can also be used for screening of aortic valve stenosis in the population. So there is an algorithm which has again been patented, now launched by Australia New Zealand group of scientists, where an ECG can tell you whether the patient is likely to have asymptomatic significant aortic stenosis. This is an old man who had a normal ECG, AI normal ECG 8 years earlier. He comes later on for a follow-up. 2016, this AI ECG shows he is likely to develop AS. And 2019, the patient has significant aortic stenosis. Echocardiogram was not done in 2016. So, for example, this is a typical echo of amyloid, the cherry on top appearance of the myocardial strain, right? And now, a AI algorithm, another algorithm, this is a weird algorithm formed by a group of scientists from Latin America, which can detect amyloid from a surface ECG. Power of cardiac ultrasound. Where I come from, like my passion is echo. So let me show you some of these. A 42-year-old male smoker, and this is the Ultramix AI that we are using in our lab. He came and this was his echo. Can anyone see any abnormality in this echo? Any regional wall motion abnormality? Even the strain is here. Nothing, right? Nothing. This patient had pain. Patient was 42 years old male, smoker. Troponin was negative. We were about to send the patient home. I thought, now that the Ultramix is there, why not feed it? We feed it. Ultramix said, tight diagonal or Raymer's disease. I said, what the hell? So I told my registrar, Baba, convince him. If he gets convinced, we'll shoot his angio. And this is the angio. Can you see this tight diagonal lesion? This LED is moderate plaque, but the diagonal, high diagonal is it's a very big vessel, another tight. Now, you will ask me, what did AI see in that echo which you and me could not see? Here is
which way?
Keep going. I can direct you from here.
You both know what's at stake here. We cannot afford to lose that list.
Yes, ma'am.
You'll be wondering why I'm showing you this. More than around 250 pairs of human eyes have seen this clip. My question is, can you tell me how many persons did you see in this clip? How many cars did you see? How many cell phones? How many umbrellas? And how many ties? Can you? You can't. You just can't. And this is what AI will do. person, umbrella, cell phone, tie, person, chair. That is how it goes. So AI can analyze data you cannot even fathom or imagine. So what I'm driving point at is diagnosis of prostatic cancer, diagnosis of Barrett's esophagus on gastroscopy, upper GI endoscopy, has been enhanced phenomenally when AI tools are used. This is a typical echo of an amyloid, right? You see this echo like this. Look at my ultramic AI in my lab. How does it see? I'm sorry. Can I go for 2 minutes? Fine. This is how the AI will see that clip. It will show as multiple numbers of grayscales. And you will know that the apex has 0 grayscale, absolutely 0. So you will know that there is something wrong at the apex. This is how the AI will see. So there are a few AI-driven algorithms. You just acquire a parasternal long axis view and just put one click, and you will get the dimension in systole and diastole. Same way, you take a mitral inflow, get 5 or 6 beats, and previously we used to do E wave, A wave, E wave, A wave, etc. Now one click and you are average with everything. 2-dimensional echo, same news. 3-dimensional echo, just one view, give one clip, one command, and this is what AI, this is automatic. The AI is doing, this is Ultramics AI. There are so many other AIs available, but G uses Ultramics the best, and you get a 3-dimensional ejection fraction very easily. RV ejection fraction, same way. Quantification MR, again, the support vector machine uses this and can classify MR as mild, moderate, severe with just 2 views. You don't have to do anything. Parasternal long axis, apical 4 chamber, keep the color Nyquist at 70, record 5 cardiac cycles. It will tell you whether the MR is likely to be severe or not, right? Even for detection of AS, the algorithms are already developed, and therefore AI-enabled echo is now in place. I am using Ultramics for the last 3 years, and I can tell you that we wrote our first paper 1.5 years back about reduction of time consumed per examination, close to around 8 to 10 minutes per examination by using AI. Constrictive pericarditis versus restrictive cardiomyopathy, right? This is the commonest question for cardiology. Now an AI algorithm is in place to separate that. Similarly, artificial intelligence and echocardiography is a very, very happening thing right now. It is available even at this moment. Now, for example, does this patient have HFpEF? Can you tell by one view? Impossible, right? You have to get E by E prime, lateral E prime, E by A ratio, etc., etc. But now, Ultramics can give by one view. Likelihood of this patient having HFpEF or no. So, right from classification of the images, optimization of images, volume calculations, and identification of cardiac diseases, now AI is going to come in a big way. Can it replace an echocardiographer? Well, time will tell. AI in cath lab from pre-intervention, intervention to post-intervention. And this is one study done in 13,000 patients between 2010 and 19, training AI algorithms for detection of vascular stenosis, right? And see here, it can detect with the accuracy of almost 90%. So those visual things, I feel this stenosis is 70%, can be always double checked with AI. Similarly, AI can localize stenosis and predict severity, sets the foundation of standardized stenosis. Another important thing in cath lab is to identify whether a given stenosis is severe or not by FFR. We do FFR. Now we can do virtual FFR, and we can do for example, this contractility appears less, this contractility appears more of the heart, right? This can again be told by AI in a fraction of a second that this patient is likely to have very poor ejection fraction. Similarly, going ahead, the QFR and the VFFR is now a reality in two labs in the country. One is Dr. Ashok Sid's lab, a reality, and second is Dr. Ajit's lab in MMM. They are just buying, they are in the process of buying the AI. So the application of AI in cardiovascular CT is also phenomenally increasing. So cardiac CT now, CT angio, can tell you the virtual histology of the artery using AI. The algorithm is not yet patented, not yet US FDA approved, but I can promise and tell you in 2 years it will be. So a future cardiologist will look like this. He will sit in the console. AI robot could perform most of the interventions, voice assisted commands, and clinical decision support system, and a virtual hologram to diagnose or to get into the place where you want to be, particularly with for the EP studies. So this is going to come maybe not 5 years, but 9 to 10 years. Did you know ChatGPT takes the European exam core cardiology? And it passed with brilliant marks. So that is going to happen. But investment in artificial intelligence have crossed millions and millions of dollars. So if you think that AI is going to die off, it is one of those things, yaar, ye aisa hi aayega, chala jayega, nahi chala jayega. Because the money invested is humongous, and those guys are not going to sit tight. So currently we are somewhere here, then there will be mass adoption, and then there will be maturation. Microsoft to buy AI firm for $16 billion, 2021. $16 billion. The bad, AI cannot reason out, okay? AI have no reasoning, which only human minds have. AI cannot do reasoning. Yes, that's a problem. Second problem, AI will have bias. Why bias? Because AI depends on the data that you feed. If you feed male data, and apply it to the female patient, it will go wrong. So the data has to be gender neutral. So it cannot be like randomized trial where 70% are males and 30% are females. No, 50-50. Then only an AI algorithm can succeed. Ugly, AI depends on data. And these companies which are invested millions of dollars in data, just like Facebook, Instagram, and that all that stupid companies, they will buy and sell this data. That is the fear. And patients' confidentiality may be lost. So we started in 2017, and these are the milestones in the AI. Scientists only have 20% of chance of making AI safe, because when the AI crosses the stage of unsupervised learning, what could be the next step will be anybody's guess. I suspect that ethical concerns are there, but the potential of artificial intelligence for making healthcare better is indisputable. The question is how to integrate successfully in our healthcare systems. For doing so, we have to overcome technical limitations, regulatory obstacles, and curb the tendency to oversell the technology. So we need to stay with AI and use AI in a very clever manner. The biggest fear which so many of the students there will have, will AI replace medical professionals, right? Now, to answer this question, do you know who is this? She's Maika. She is the CEO of a Polish beverage company, Dictador. She is a humanoid robot. August 2024, Dictador, a Polish rum company, appointed Maika, a humanoid robot, as its official CEO. And she has outperformed all the previous 6 CEOs in less than 9 months so far. Go on the Google and check. You will have her interviews, And in a Reuters video interview, which is there on the net, Micah says she operates timelessly 24/7, working 7 days a week. She says, I don't have weekends. I'm always 24/7, ready to make executive decisions and stir up some AI magic. So whether robots will replace us, time will tell. But because AIs don't have consciousness, they can't reason out. Neither man nor machine can replace its creator. And I take a breath at that, and thank you very much for listening.